Was professor of surgery at the Division of General and Minimal Invasive Surgery and director of the Minimal Invasive Surgery Fellowship at the University of Texas, San Antonio. The floor is yours.
Thank you. Good afternoon. These are my disclosures. I'm certainly open to additional, but this is my only one. Sweet. I get to do the talk on data. Don't know how I drew that short straw. I must have offended someone on the program committee. For that, I apologize. Post-lunch, try to stay awake. Okay, welcome to Tennessee, y'all. I'm from here, and I grew up over yonder in Kingsport, which is about 250 miles east of here. I saw somewhere on the internet where this area is now referred to as Appalachistan, which I love. Those are my favorite pants, and I am going to the game on Saturday. And if you ever get a chance to visit the Smoky Mountains, beautiful, breathtaking. Okay, so preoperative optimization, aka prehabilitation. This is a term that's been, I think, brought more to the forefront in the last 10 years or so. It's these multidisciplinary approaches, focus on patient improvement, specifically modifiable risk factors, things that we all discuss in these meetings like nutrition, weight loss, smoking cessation, stress reduction, and of course the goals are to improve outcomes. So when it comes to hernia hernia repair, the big three that we use in our clinic are smoking status, which Smokey says, smoky, smoky, no pokey, pokey. Glycemic control, A1C of less than 8 or no date. And then weight management, if BMI is over 40, then oh lordy. So we'll look at each one of these individually and go from there. I think most of you are familiar with this study that Dana Tillum and her colleagues did at University of Michigan, and where they had a specifically dedicated preoperative optimization clinic looking at high-risk patients, for patients who were being considered for hernia repair that were undergoing just watchful waiting because they were too high risk. So they deliberately sought out high BMIs, elderly patients, active smokers, and they wanted to see if they could implement a program to move the needle a little bit. And it was a fascinating study, and they certainly spent a lot of time and effort and resources to try to optimize some of these higher risk patients. But at the end of the study period, it looks like only around 10%, 15 out of 165 sort of crossed over into the surgery eligible arm. But they did view this as patients whom would have otherwise not been considered for surgery. And they did see a slight increase in things like clinic visits and RVUs. But I think the question in that one was, is the juice really worth the squeeze? Smoking certainly gets a lot of discussion in this meeting and other meetings. Jonas Stuhlberg, when he was at Northwestern, looked at this using the ACS NSQIP database over about a 3-year period, a huge number of patients, and looked at the impact of smoking, active smoking, within the last 12 months. And not surprisingly, in that study, they found that current smokers had higher rates of pretty much everything, any complications, readmissions, reoperations, wound complications, et cetera. And based on their findings, they suggested that smoking cessation should be considered in just about all these patients. Odds ratios were all greater than 1 in the smoking groups. Current smokers had higher rates of every complication that they basically looked at. So again, smoky, smoky, no pokey, pokey. But a lot of the hernia nerds decided to look at this and go, what about hernia specific? These were general perioperative complications, but not hernia specific. So there were a couple ACHQC database reviews that have been published recently looking at perioperative smoking. And here's a study looking at inguinal hernias. This is an ACHQC study that looked at smokers and found a propensity matched group of non-smokers and looked at 30-day outcomes. And interestingly, they found no differences in inguinal hernias and SSIs, SSOs, and SSORIs. What I did find interesting in their distribution was it was about 33% of open lap and robotic inguinal hernia repairs at that period of time. The majority of these were with permanent synthetic mesh, and not many were using biologics or biosynthetics. Which is interesting, that non-smokers were more likely to be admitted to a hospital post-op, and that smokers had higher improvements in the quality of life scores. And this is sort of a table representing the same thing. So there's another study that Mazen Al-Mansour and his group in Florida looked at, another ACHQC database review. They actually teased out 3 different groups of smokers, which are never smokers, former ones who had quit more than a month ago, and or current, which are active smokers, and they looked at 30-day outcomes. And in this group, one thing I do find interesting, a lot of these reviews of hernia repairs is that just about all these studies demonstrate that somewhere around 10% of all the hernia repairs being done are being done for recurrent hernias, which of course is this paradox between the published recurrence rates of hernias and what you see in these types of studies. But essentially, the overall complication rates were similar in current, former, or never smokers, 9, 9, and 7%. And the SSI rates were low, 6 and 4%. And there were really no statistical differences between current and never smokers or current and former smokers. So the Breakfast Club, smoke up, Johnny. Shouldn't be a problem for inguinals. All right, A1C of less than 8 or no date. Where did this come from? Largely attributed to Mike Liang and his group that did a comprehensive expert consensus report looking at systematic reviews and grades of recommendations, A, B, and C. And there was general agreement among this group of experts, most of whom are sort of charter members of AHS, that there was grade A recommendations for obesity, smoking, and A1Cs of greater than 6.5. The recommendations in that study were elective ventral should be avoided in high BMI patients, but low grade of evidence, current smokers strong, and then A1C of greater than 8 with a grade B recommendation. Interestingly, also recommended mesh reinforcement for hernias greater than 2 centimeters. Mike Rosen and his group looked at open TARS in regards to glucose control at Cleveland Clinic. This was a 10-year ACH QC database review looking at the similar type 30-day perioperative outcomes. And what they found is that they sort of broke their diabetic patients into 3 different groups, sort of optimal control less than 7%, sort of the suboptimal between 7, 8.5, and then the poor, which was in their study greater than 8.5%. And what they did find is that patients who were diabetic tended to have higher rates of SSOs, SSOPIs versus the non-diabetic group. But between group comparisons, if you just look at the p-values of all these different perioperative outcomes, the differences between these 3 different subgroups of diabetics really was not significant, with the exception of seromas. The poorly controlled group, the A1C greater than 8.5, tended to have higher rates of seromas. Obesity, body mass index greater than 40, doesn't matter. So there was a review fairly recently that Richard Liu, who's now down in Galveston, looked at, looking at systematic reviews of body mass index and results in ventral hernia repairs. And this may not surprise many of you in the room, but even with BMIs greater than 40 or greater than 35, in their review, they really found no differences in outcomes in recurrences, seromas, hematomas, surgical site infections, regardless of their body mass index. These are just the box plots of recurrences and seroma formations between the groups with high BMIs. And again, no statistical significant difference was found in that study. My bias on obesity is that distribution matters more. Body mass index, as most of you know, is a really poor proxy for obesity. That's a term that life insurance companies have used. It was adapted from a statistician about 100 years ago. And now tragically, it's become sort of a cardinal metric in healthcare. But to me, the absolute number BMI matters less than the distribution. A viscerally obese male, for example, has a much higher burden in their abdominal weight and their abdominal pressure than the peripherally obese female. And I do think that makes more difference than the actual number itself. This was just published not that long ago. Dr. Petro and Dr. Rosen at the Cleveland Clinic sort of looked specifically at this whole soup to nuts prehabilitation concept. You know, are we really optimizing these patients in these heroic efforts in the outpatient clinic setting, or are we just sort of stalling and kicking the can down the road, so to speak? Their focus, like I'd say many of us in the room, is to do a nuanced approach, a very individualized approach. One size does not fit all. Smoking cessation is not an absolute mandatory requirement now in most of these abdominal reconstruction cases, largely based on some of those ACH-QC studies that were just published. Their obesity management, I think, is similar to what we're doing. There's no true hard BMI cutoff. It's all sort of relative based on defect size, distribution, and whatnot. a goal of A1C less than 8 is considered ideal, but to me, the acute glucose control matters, what their daily blood sugar checks are, and how well they control their sugars on a day-to-day basis. And when it comes to some of these risks or predictive models, I think most of you have seen these, but these started coming out in the late 2016s or so. The French Hernia Club did a review of patients who were at highest risk for incarceration. This was a large number of surgeons and hospitals. What they found is that patients of increasing age, BMI, and ascites patients, periumbilical defects in particular, and a defect width between 3 and 4 centimeters, higher risk of acute incarceration. The hernia to neck ratio, which I think now is pretty much common nomenclature for most hernia surgeons in the room. But this concept of the difference between the hernia sac width and the defect width, I think has bumped up the priority ladder to being at or near the top of the list of importance because of the pressure gradient that is created between the difference in a skinny neck and a wide sac. So this hernia to neck ratio is critical. Most of these are measured on the sagittal view on a scan. So you see that scan on the left-hand side has a much higher neck to sac ratio than on the right-hand side. And the higher the neck to sac ratio, the higher the risk of incarceration. In this particular study, they did a receiver operator curve. I'm no expert by any stretch on this, but when they found that the hernia neck ratio was greater than 2.5, that the odds ratio of an acute event was 53, which I'm not sure I've ever seen an odds ratio that high for a specific risk factor. There was another group, one of our former residents, Dr. Putnam, looked at this and they found similar results, which is that the smaller the hernia neck or the higher the hernia neck to ratio was, the more likely these patients were to present acutely with incarceration. So I guess the overall take home from this is that it's certainly appropriate to consider, particularly as complex abdominal wall reconstructions. But I would think at this point for inguinal hernias and perhaps even small ventrals or umbilical hernias, particularly MIS, lap, and robotic, some of this optimization is probably not ideal. I do think the hernia neck ratio probably has the greatest impact on these ventrals and I think should be considered first before smoking, BMI, and glycemic control. At our institution, we were actually trying to build an obesity severity index within EPIC to be more granular and quantify obesity on a much better level. So with that, I'll wrap up and move on to our next speaker.
Thank you so much for that presentation. Coming up next is Dr. Eric Pauli. He is the David L. Narwald Professor of Surgery at Penn State Health in the Division of Minimally Invasive Surgery and Bariatrics, and he currently serves on the AHS Board of Governors.
Hey, well, thank you very much for the opportunity to present, and we're going to continue talking about how to manage patients beforehand surgery utilizing radiology to plan your next case. And I think Kent gave us a very good tease as to what we'll talk about here in the next few minutes. I also have a number of disclosures. I don't want any more. Thank you very much. So I'm going to talk for the next few minutes about using CT scan to plan imaging for your hernia repairs. There's a lot of information present on those scans that's going to help you make a good plan for surgery. And I think about this every time I'm looking at one of these. For me, I tell my fellows, hernia surgery isn't really about surgery. It's about thinking about hernia surgery. It's kind of like fishing. Fishing isn't about fishing. It's about thinking about fishing. If you go to the wrong place with the wrong bait at the wrong time, you won't catch any fish and you are therefore not fishing. If you go to the OR with a wrong plan on the wrong patient at the wrong time, you're going to have a bad day as well. And so if you give me 6 hours to chop down a tree, I'm going to spend the first 4 sharpening the axe. And that's really about making the plan for surgery. And I always like this quote from Yogi Berra: if you don't know where you're going, you're going to end up someplace else. And I am not a surgeon who likes surprises. I like to know what I'm going to do in the OR, and then I like to go do it in the OR, and then I like to go home. So imaging in hernia, you can use it for a lot of different things. We know about diagnosis. We're going to spend today's time talking about preoperative planning. I use it in the operating room quite regularly. I'll stop, go to the scan, look at it for a few minutes, ask myself, what am I about to get into in this section of the dissection, and then go back to the patient, managing postoperative complications and then long-term documentation as well. But let's focus a little bit on imaging here. We're going to spend most of the time talking about CT scan, and the reasons are pretty apparent, I think, as hernia surgeons. This is widely available as general surgeons who do other general surgery things. We're familiar with this. You can see both the abdominal organs and the abdominal wall itself. And so you get a lot of additional information that may help you. It's relatively inexpensive in the grand scheme of imaging studies. What I like about it is not user dependent. The images have all the data on them. What's user dependent is the report, and I don't need the report. I need the images myself. And so I can take any scan from any hospital done locally or far away, and I can figure out what's on it regardless of what the report says. The downsides, you do have to radiate patients, and they can be sort of pseudodynamic. You can have patients do Valsalva maneuvers and things like that. My patients in Pennsylvania cannot figure out how to both hold their breath and bear down and not move. They just can't do it. And so I rarely use Valsalva, but you can get some pseudodynamic images if you want. Imaging is really where the rubber meets the road, and I think it's the interpretation that's the problem here. There is a very big discordance between how radiologists view hernias and how hernia surgeons view hernias. So I want you to take a look at this image that we have here, which was read by my radiologist as having a sac this big and this wide. That's really what they reported. No report about the diastasis on the film, and I'll show you in a few minutes. It's actually more than what they think it is. Ventral hernias are the second most common structure to be inaccurately reported on CT scans, and they are the most common misfinding on CT imaging as well. And on this patient, all you have to do is do a quick sagittal, and you actually realize there's actually not one hernia there. There's actually two separate hernias. And so they were measuring some random amount of both of those little preperitoneal fat sacs together. So again, a simple film to show you how easy it is to get it wrong, even on something as simple as a primary umbilical defect. This is also an everyday occurrence. I know that you guys have this problem, and it's really about the report. So here's a patient that I operated on earlier this week. This was my Tuesday patient, I think, Daphne, Tuesday we did this. Here's what the report says for that: epigastric fat-containing ventral hernia with associated diastasis recti. They missed the full laparotomy she had. They missed the old stoma sites. They missed the big hernia. They missed the piece of mesh that's in the abdominal wall. Okay, so there's a lot that's missed on this report that says that that is a diastasis. So when I meet somebody, I think it's actually much more about the scan than about being very comprehensive. And so anytime I talk about radiology and imaging, I always talk about the three things that I need to be good at looking at a CT scan. That's a physical examination of the patient. It's the actual imaging, not the report, and it's the old operative notes. So why the old op notes? Well, number one, it's nice to know what people were doing before you got there. And I use this as a prototypical bad op note. I don't know what a left paramedian juxtaumbilical ventral abdominal hernia incisional is, but I do know this person had a surgery somewhere near their umbilicus. And so I can focus my attention on that area if I'm looking for mesh or other problems. Was mesh used? Was it described in the report? Where did they place it? What kind of mesh was it? That's all information that you're not really going to easily get from the film unless you have an understanding that it's potentially there. And it's also nice to know what anatomic planes have been violated before you go and try and redo something that was already done. I think it's also important to look and ask yourself, if they describe doing a component separation, does the CT scan support that, yes or no? Because it's not uncommon that I see somebody has a scan that says that they had an external oblique release, but on the scan, the external oblique has not been released. And so it's nice to know if you're going to be redoing something, whether the first person did it properly or not. I oftentimes get asked, do we really need to get the old op notes? This is some work from Michaela Blake when she was with Mike Rosen at Cleveland. And they asked 15 expert abdominal wall surgeons to review scans. And they gave them a multiple choice survey of what do you think happened to this patient? And all that was given was the scan. And if surgeons have the scan, they were only able to identify the correct ventral hernia about 50% of the time. Now, that's not bad because there were 4 multiple choice options. So randomness would tell you you're going to get a 25% chance. So we're better than random, but we're still not, particularly good at doing it. And so without knowledge of prior repair, surgeons also are going to find it difficult to figure out what happened. But this is why we're better than radiologists, because radiologists sit in a dark room without the prior knowledge of the report and without the patient there to look at scars and to do a physical examination. And so when you put all of those things together in the same room at the same time, then you're going to be very good at looking at that CT scan. So why is physical exam important? Well, physical exam misses hernias about 20% of the time, but there are things that you will see on exam that you're never going to find on a CAT scan, and also vice versa. And so I think that the imaging needs to augment rather than replace the physical exam. And I think, again, this patient of mine is a good example. You can see the CT scan on the left-hand side there. This area here is this area right here. All of this was read as normal. I think the radiology report actually said that there was a diastasis rather than a bridged mesh-based repair. But this patient has pus coming out of his abdominal wall. He's got mesh extruding from the abdominal wall. And even with that knowledge, when you go back and look at the scan, you cannot look at that scan and say, oh, that's mesh being extruded. It is not on the films. It's kind of hard to blame radiology for missing that sort of stuff. Now, together with some of my Brazilian colleagues, I think some of whom are here in the room, we sort of put together this idea for a very comprehensive radiology report of what this would look like. And, the problem is this is great. But when you give this to radiologists, they tell you they do not have the time or the ability to do this. They don't have, they don't have the hours of the day to do it. I think this is going to be a very big area where artificial intelligence actually helps us substantially by providing us with very specific abdominal wall radiology reports that give you all of the information that you as a hernia surgeon would want to know. Let's talk very briefly about finding mesh on imaging. Since I said earlier, it's hard to find. Mesh is easiest to find when it's surrounded by something that it is not equally dense to. Most mesh and muscle are equally dense. And so when there's fat surrounding the mesh, that makes it easy to find. Good news, bad news. Good news. When mesh is against muscle, oftentimes you don't have a recurrent hernia. When hernia surgeries are poorly done and there's fat surrounding the mesh at baseline, it's going to be easy to find, and I'll show you some examples of that. You can also look for non-anatomic folds and wrinkles and for radiopaque fixation, and then obviously by reading the old op note, you can have some idea of where you're going to look to begin with. So let's look at a few pieces of mesh here. That's mesh on imaging, and I know that because this was mesh that was placed laparoscopically as an IPOM repair. The falciform was not taken down. There's omentum on one side, there's falciform on the other. Humans don't wrinkle on the inside, and so that's mesh. This is a patient who has some mesh in the preperitoneal space, and if you look carefully, you can see some very subtle sawtooth waves here in the midline. You can see that there's some preperitoneal fat surrounding the mesh, and so you can identify that. This mesh has radiopaque fixation, and so we can see the fixation points. This mesh is also EPTFE. The mesh was short-sheeted to the patient's right-hand side because the surgeon put ports only on the left, and they short-sheeted the mesh to one side. And so you can actually begin to predict some mechanisms of recurrence by looking at how the mesh is miscentered. This is an onlay mesh, which is able to be seen because the mesh is not against the fascia. There's some fat here, and you've got some radiopaque fixation as well. This is some retromuscular mesh. The mesh itself is challenging to see, but somebody put some clips in the retromuscular pocket, and so you have an idea of that somebody was there ahead of time. This is one of those poorly placed meshes, which has fat on both sides. It's just an IPOM mesh that is more or less freely floating against the abdominal wall, so easy to see. This is a patient of mine who has a bridged repair with 4-hydroxybutyrate. Radiology called that a wide diastasis, which I took as the highest compliment because this person had a massive hernia and a fistula, and now he just has a wide diastasis, and he was actually pretty happy. But that's actually a bridged mesh. Now, this is one of the areas where mesh is challenging to find. This is a retromuscular repair. It's a reduced weight mesh that's directly behind the muscle. There's not really fat on either side, and so there is mesh behind the muscle. You just can't see it. This one is a little bit easier to see because the mesh has a couple wrinkles. Again, in the midline, those little sawtooth waves there are some small wrinkles in a retromuscular mesh. Last couple of questions that I ask when I'm looking at a scan. If the patient has a history of a bowel obstruction, I want to know, is the obstruction related to the hernia or related to something else? This is a patient who has had a cystectomy. And again, I think you should be able to look at a scan and see a loop of bowel that looks like this and say to yourself, I'm concerned that that bowel is going to be stuck there. Doesn't mean you have to do it lap or open or robot. You do however you prefer, but I think just be aware that that bowel is going to be stuck. This is, again, an opportunity where I use imaging in the operating room as well. This is a patient in whom I was having a very challenging time getting this loop of bowel off of the back of the rectus. So we went to the scan and asked, what is that loop attached to? And the answer is it attaches to the gallbladder. If that's the gallbladder and that's a loop of bowel and that loop of bowel goes down, it's actually the duodenum. So this patient's duodenum was plastered to the back of the right rectus. And again, just a few moments in the operating room to spare yourselves a duodenotomy as opposed to a regular old enterotomy. And you can see how plastered that bowel was stuck there. I'm going to actually just skip through the next couple of slides. I think Kent did a pretty good job going over these predictive models for how you plan repairs. I'm going to just briefly touch on this one, which is an odds ratio of emergency hernia score. I think that this is a very valuable tool to look at somebody who you see in clinic who might not be optimized yet and in whom you have to ask yourself, is this a good patient for surgery, yes or no? Only thing I want to caution about this odds ratio score is that you're getting 7 points if the patient has ascites. And this is real ascites. This is like I have cirrhosis ascites. And let's all be honest that this is already at baseline not a good patient, okay? So if you're having ascites, it's a very common reason for incarceration. And so I would caution you about doing that. I'm going to skip over the last couple of slides here because it's really about the hernia neck to sac ratio, and I think Ken did a pretty good job. So in the interest of time, I'll just kind of skip over those and just remind you that you can do it not only for umbilical hernias, but you can also do it for ventral hernias as well. Lastly, some work from Todd Henneford's group about using radiology and artificial intelligence together. Todd's group basically fed CT slices to a deep learning matrix and just asked it, predict whether this person is going to have a pulmonary complication, a wound complication, or need a component separation. And again, on receiver operator curves, the artificial intelligence was actually able to successfully predict surgical complexity based off of the need for a component separation, and it was more accurate than an expert surgeon. And so when we think about how to triage patients to a hernia surgeon who does simple repairs versus a hernia surgeon who might do more complex repairs, radiology may be able to guide us and lead us there. So imaging can help you plan a good repair. I think it'll help you become a better hernia surgeon. You get a good imaging review, you get a good plan for surgery and a good outcome. You can certainly rely on radiology reports, but I think you're going to have to give them a lot of additional information to get good information out. And I think there's a lot of cool stuff coming. Thanks very much for the opportunity to present.
Thank you, Eric. Thank you for being exactly within the time schedule. The next speaker is Professor Leandro Totti Cavazzolo, if I say it right. He's associate professor from the Department of Surgery, Federal University Rio Grande do Sul, and that's the floor is yours.
Yeah, thank you very much. Thank you for the American Hernia Society for the invitation. And as you guys know, we're going to discuss about ERAS. This is my disclosures. And ERAS is a very huge effort trying to decrease postoperative morbidity and complications in our patients. It has usually three parts. The pre-admission phase, which I think was very well discussed before. It has an preoperative or intraoperative phase, which regards everything that we can do on the surgery or in between surgery. And it has a postoperative phase that we work on the rehabilitation of the patients, taking back them to the society. For me, this is a very interesting consensus that was just came out from HSQC. And I'll show you guys from each one of these three parts of the ERAS protocol what we have in the literature. It's not a systematic review, but we can see from all of these steps of the ERAS protocol what we have evidence. So regarding nutritional evaluation and metabolic optimization, there's no specific papers regarding ventral hernia repair, but since this is a minimal risk for the patient, especially in those huge hernias and patients with that are very debilitated from the previous repairs, we should consider giving these evaluations for these kind of patients. We already discussed weight management, and even we understand that for a very big, it remains a strong recommendation based on a weak evidence, and especially in the United States, you guys really push the limits for very high BMIs. So there's not a specific BMI where we can say that it's safe or it's better to operate these patients, but we can discuss this later. The evaluation of functional status, since there's a low risk intervention, and there's a moderate evidence to support, every patient that can and has a poor baseline status should undergo physical therapy. Probably from the preoperative standpoint, one of the most controversial, especially here in US, is smoking cessation. And even for overall health benefits, there's a strongly advisor for smoking cessation before surgery. In modern hernia surgery, probably because we use minimally invasive surgery and other interventions that reduce the postoperative complications, in hernia, this is not less clear. So in my opinion, and most of this will be based on what I saw from the literature and from what we use as an ERAS protocol in our place. Of course, we should always ask patients to cessate smoke before the surgery. This is something interesting for me. The screening for obstetric sleep apnea. There's a lot of papers showing a reducing if you use positive airway pressure before surgery in the big hernias, you can have at least a 30% reduction in postoperative complications for these patients. This was already showed by our previous speaker. It should be checked, and even if there's not a clear cut, it should be evaluated and it should be corrected when possible. For alcohol use, there's no recommendations, thanks God. We can still drink some before our surgeries. There's no high quality evidence to support screening. And we should, in my hospital, we are not obliged to screen for MRSA in these patients. This regards all that we discussed so far is regarding the preoperative phase or before the hospitalization. What we can do in the perioperative or the intraoperative part of regarding the ERAS protocol, we can, for example, use a lot of adjuvants to analgesia, especially to reduce the postoperative opioid consumption. There's a lot of data that shows even if we go straight to TAP blocks or regional blocks, they are not clearly identified for ventral hernias. If we go and we have a lot of alternatives, we can use TAP blocks, we can use rectus sheath blocks, we can use in some big cases, erector spinal blocks, and we can use even epidurals, for example, if you're doing an open surgery. And you have benefits to reduce the opioid consumption, for example. This is a very interesting meta-analysis was done by the group from Montefiore, showing a shorter length of stay, showing lower pain scores in the immediate postoperative period and the PO day one, showing that the TAP blocks is associated with important reduction in in reducing the length of stay. And if you go to other papers, this will show almost 2 days of reducing length of stay in these patients. This is a randomized controlled trial with a small number of patients, but showing better results in 6 hours, a reduction in length of stay when you put multimodal therapy to reduce pain in those patients. So reducing opioid consumption and having a good impact in all of these variables. Of course, when to avoid nausea and vomiting, it's important to use antiemetics. This is very important if we understand that these patients will have an increase of at least 6 millimeters of mercury or greater. We should understand that these patients should be remain intubated. So this can be planned in advance, measuring the airway pressure on the beginning of the surgery and after compression. A careful intraoperative fluid management, avoiding edemas, and of course enhancing the pressure. Right now, we get to the last phase of the surgery, which is the postoperative. And I really want to ask you guys, apologize, because it's a very huge protocol. So we have to go in all of these things. So again, the same thing that we decided during the surgery, we should maintain on the postoperative phase. So we have to avoid and limit the use of systemic opioids. And this is much more important in US than is in my country. We can discuss this after if we have time. These patients should be strongly recommended to have VIL immobilization. This will allow the ball movements to get faster and early in the postoperative period, and these patients will be better on a short period of time. Of course, there's evidence to use prophylaxis. The postoperative antibiotics is a very important and interesting part. There's no support. People sometimes try to use postoperative antibiotics until they take out the drains. There's no place for that regarding these reviews. Patients should be encouraged to have feeding as soon as possible. There's no data to support the laxative use. This is a different opioid with less impact on the digestive motility. There are at least 3 big studies showing that this probably is good for the patient. So this is probably something that will be used more often in the future. We don't have this in Brazil. Regarding the postoperative fluid, is the same thing that we have for the intraoperative part. We should use it with cautions. As far as urinary drainage, you should be removed as early as possible. For drain care use, there's no data to support the routine use for small hernias, but for the big complex cases, we should use drains for that. This is very interesting for me. The abdominal binder, since there's a low risk and a cost-effective, in a way, you can use in all these patients with no more harm for them, and this can improve pain and mobility. This is a recommendation that should be used. So wrapping up, if you go and see specifically in ventral hernia repair, there's a lot of data showing the decreased length of stay starting from 0.7 days until almost 2 days, a faster return to bowel function, fewer 90-day readmissions, and lesser use of opioids and decreased incidence of surgical site infections. So probably one of the most important parts, especially in US with the money question, is the significant decrease in the length of stay when you start in practice. For example, in this case, early mobilization and all of the other parts of the protocol show an acceleration of the discharge of these patients. So at least from 0.7, so the compliance with these protocols probably will have a very good impact on this for these patients. It's difficult because there's no standardization. Each institution uses one protocol. It's difficult because the patients it's not everybody that adheres to the protocol. There's variability in the surgeries. You have to convince your team, and you have to convince them to change. So my take-home message, and if you put this QR code, you'll be linked to this presentation on PDF and to the articles that I discussed. I'll summarize that. Of course, I won't read this, but for you guys to understand, we have to work in all the 3 parts of the AROS protocol, in the pre-admission optimization, in the perioperative and intraoperative variables that we can change, and especially on the postoperative period, we have a lot of things that we can use the AROS protocol so we can have better results for our patients. This is an invitation for our postgraduate course, and I would like to thank again the American Hernia Society for the invitation to share the podium.
Thank you so much for that comprehensive review. Up next, we have Dr. Sullivan Ayuso, who is an assistant professor of surgery at the University of Texas at Austin in the Department of Surgery. And he's going to be talking about preoperative adjuncts to complex abdominal wall reconstruction.
Thanks to HS for allowing me to talk about some preoperative adjuncts today. I'm at the other UT, Dr. Van Sickle, so I'm in Tennessee, so I'll say that. So here are my disclosures, none of which are relevant to this talk. So when we're thinking about hernia repair, the way to approach patients, I think generally is to think about how are you going to get their anterior fascia back together? And then secondly, what type of prosthetic are you going to use, or where are you going to put it? And so that is really the purpose of this talk from an overarching standpoint. How can I optimize the chances that I actually get the fascia closed and then prevent the need for a bridging mesh and all the complications that go with that? So there are a lot of fancy adjuncts, and that's what I was asked to talk about today. But the first thing that I want to start with, which has already been alluded at earlier points in this panel, is weight loss. So what does weight loss do for us? There have been a number of really good studies. This one that I want to point out was done by Katie Schlosser. Weight loss of just 10 pounds before surgery can reduce the intra-abdominal volume by almost 150 centimeters cubed. So this is, and if you double that and you lose 20 pounds before surgery, you double the intra-abdominal volume loss. So first and foremost, these are things to think about, in particular with complex patients. So how do we do this? We do this through all of the things that have been talked about to this point. So lifestyle modification, diet, and exercise. We do this through GLP-1s. There are a number of really good papers that have come out in the last couple of years looking at time to operation. And then lastly, bariatric surgery. If patients, have the time and they don't have a hernia that is kind of needing more urgent repair, those are something to consider. And then something that we're writing about right now is the endoscopic ability to optimize these patients, specifically through endoscopic sleeve gastroplasty. And so this can be particularly useful for patients that have had a complex surgical history and avoiding the entry into the abdomen. What I'm going to spend most of the time talking about today, though, is the use of preoperative Botox. So many of us are familiar with Botox and the cosmetic use. So acetylcholine release is prevented and thereby preventing this synaptic connection at neuromuscular junctions and causing a form of chemical relaxation to the lateral abdominal wall. And so this is done a number of ways. There are a number of different protocols that are described out there in the literature in terms of how much Botox we use or how much botulinum toxin, should I say, that we use, what type, and where it's actually injected. But again, the point is to relax and cause a chemical component relaxation and then ultimately help with the anterior fascial medialization. So who gets it? So this is why we're all here today. And I wish I had an easy answer for this, but ultimately this is more of an art than a science, right? So loss of domain, you know it when you see it. Patients that have a large amount of their intra-abdominal cavity outside of or their hernia sac outside of their intra-abdominal cavity with the defect, a lot of people have published on is the width greater than 10 centimeters, 15 centimeters. What are we talking about? And then consideration of location on the anterior abdominal wall. This has actually come up at this meeting already. Is the hernia itself next to bony structures? Are there things, is this an M1 or M2 hernia? And then the surgical history. Had there already been a mechanical component separation, and are we needing more to achieve the result of anterior fascial closure? So this is the protocol that was adopted from Carolinas, where I did residency training and did a research fellowship. But starting with 4 weeks prior to surgery to optimize the ability of the Botox to work, injecting 200 to 300 centimeters at 6 different locations in the anterior abdominal wall. We don't routinely inject the transversus muscle. There are people out there that describe doing that. However, there is no documented benefit to doing all 3 layers in the lateral abdominal wall. People do this under ultrasound, CT. Some surgeons elect to do it themselves. Here is a picture from, again, from the Carolinas showing injection of the superficial 2 layers here of the abdominal wall. I alluded to this a couple of slides beforehand, but this is a great work that was published by Monica Poltz looking at the amount of patients with M1 hernias who ultimately required component separation after getting Botox. So you got Botox, you had an M1 or M2 component, you still needed component separation, and this is a size match study. So suggesting that if a hernia is closer to the costal margin, you still might have to do the component separation. Botox may potentially be less useful. And there are a number of good single institution studies. We're lacking any sort of randomized evidence at this point. looking at the efficacy of Botox. But this is a paper that Dr. Derenberg published. Is a propensity match study looking at the use of BTA versus no BTA matched on very important hernia characteristics. And what this study found that there was increased rate of fascial closure. And again, why is this important? You're preventing the use of bridging mesh, which is associated with a higher risk of wound complications, and then ultimately a less durable repair, right? So we know patients that don't have their anterior fascia closed have a 5 to 7 time chance of actually developing a hernia recurrence. We expect them to recur. So this is pretty important stuff. Another study that I was associated with looked at taking patients that had Botox only versus component separation only, and what that meant for their postoperative complications and outcomes. So there was no difference in fascial closure rate, again, in a size match study, looking at BTA only versus component separation, and decrease incidence of surgical site occurrence, which is what we would expect, particularly when we're talking about traditional anterior component separation, where you're developing large subcutaneous flaps. So this is one of the most important slides, I think, in this talk, and it looks at the rate of component separation, and this is data from the Carolina Center since the introduction of Botox into practice. And what you see in 2016, which is the first year that this was more routinely used, that component separation was being done on almost 50% of patients. And so this is either a TAR or an external oblique release. And then if you look at the amount of component separation that was done over time, and hernia defects that were the same size, there's actually less component separation being performed, and dramatically so, while Botox has hovered about 10 to 15%. So this is quite impressive data. Some other things, and Dr. Paulai alluded to this in his talk, is we're trying to study exactly who may benefit from preoperative Botox. And this, I think, is the question that we all need to answer as a hernia community in the next 10 years. But using AI and preoperative CT scans to say, what patients would actually go on from getting component separation. So some of the work that we've done here is actually developing deep learning models using preoperative imaging to see who may or may not need a component separation. So training a model on this. And then one of the interesting things about this is we were able to have an internal test set of patients that had preoperative CT images that did require component separation, that did not have Botox use. And what we found is that based on kind of the algorithm that we developed from patients that did have Botox use, that about 40% of those would have been spared from a component separation. So again, this is consistent with our data here. When we look at large scale data, what I think we have found is that this does help in terms of that anterior medialization of the fascia at about 4 centimeters. But again, the protocols are kind of all over the map, so we need better data here. The thing that I think is important is that there are a lot of serious complications that have been noted in the literature with this, and so I think one of the biggest barriers to this is getting this approved from insurance, since it is indeed off-label in abdominal wall reconstruction. A lot of times, people need to actually write letters to insurance companies to get this approved. So no guidelines yet. And I think there's going to be more to come here in terms of high quality data and how we can exactly use this and for what patients. The next thing that I want to touch about a little more briefly is progressive pneumoperitoneum. So what is this? For some of you that this is a little bit less familiar topic, it's insufflation with air, most commonly, to help expand the intra-abdominal volume, actually provide a bit of a dissection prior to going to the operating room for definitive hernia repair. So this is actually increasing the overall volume and allowing the contents of the hernia sac to actually be accommodated back into the belly at the time of the hernia repair. And so this is a really good image from our friends in Australia. And what you see here is that this patient actually had Botox and progressive pneumoperitoneum, but from the second and third images, you can see that there's a massive expansion in intra-abdominal volume after a patient received progressive pneumoperitoneum. Again, a lot of variability here in terms of how people do this. A lot of folks will tend to actually go to the operating room themselves, place a peritoneal dialysis catheter or Hickman catheter, and then typically wait a few weeks and will do some degree of air insufflation at the time of the operating room, and then continue this over the course of the next several weeks to really kind of maximize that space and allow us to have a better chance for fascial closure. The important thing here is that essentially we're creating a chronic abdominal compartment syndrome, right? And so When your belly is really greatly insufflated, this can increase the risk of DVT. And so it's our practice to keep patients on Lovenox at the time that they're getting these pneumoperitoneum insufflations. There are a lot of factors, to consider. One is this a patient that you actually keep in the hospital and do this under a monitored setting, or do you bring them back to perform these air insufflations multiple times? It depends on, where the patient's living, their comorbidities, other things to consider. I tend to find this more favorable in smaller defects where there's still a great degree of loss of domain. You're able to actually kind of open things up and have the contents of the hernia fall back intra-abdominally. And so this is a really neat equation that was presented to us by friends from Greenville in South Carolina, looking at how successful pneumoperitoneum might be. And so, one of the things that they do is they actually get CT scans before and after they do their progressive pneumoperitoneum protocol and do volumetrics. And if essentially the post progressive pneumoperitoneum CT scan has a abdominal cavity volume that's greater than the sum of the hernia and the abdominal cavity volume prior to progressive pneumoperitoneum, then they're more likely to have success at closing the fascia. Again, the review of the literature, techniques are all over the place. It's most common that every 2 to 3 days, people are having these insufflation. People hook up to the wall to ambient air. Others inject with a catheter, which is what we prefer to do, but very high fascial closure rate for very complex hernias. And so the combination of the two, I think this is also poorly understood. I wish I had better answers for you guys today. But it's not uncommon to take a patient to the operating room, do Botox injections, and then place a progressive pneumoperitoneum catheter of some sort, and then come back and actually do that protocol. What the literature has shown there is that it's quite successful in helping, close fascia and decrease the risk of component separation. But exactly, how those things kind of correlate and help each other is unknown. And so briefly, I'm going to touch on tissue expanders. This will just be a couple of slides to keep in time, but this is more so for my plastic surgeon colleagues. I saw John Fisher in the room earlier. He'd be the better person to give talk on this, but mostly when you're going to face challenges with soft tissue coverages, so patients that had multiple laparotomy skin grafts, or have had abdominal wall debridements, and this is when you would consider using a tissue expander. It can be subcutaneous, they can be in the muscle, they can be intra-abdominal, and it works basically through mechanical force over time. And then also there are some changes at the cellular level that kind of help remodel things and allow for the recruitment of tissue. These is just an example of the different types of tissue expanders that are used, and then the types of incisions that can be made. Again, if you're trying to advance the skin and the subcutaneous tissues towards the midline, then that's okay to use an incision that's kind of adjacent to the skin graft, which is the most common reason that we use this. Typically, the expansion is a gradual process over time. You place the expander, blow it up with typically 10 to 20%, and then kind of serially insufflate to create coverage. And then I think this is the most important part of this slide. So when you look at the circumference of the tissue overlying the expander, and then you subtract that from the base diameter, and that's the amount of tissue essentially that you're going to be getting to provide the advancement. So when you have that, then you're ready to go for a definitive hernia repair. Some considerations here: quality of skin, right? If you're doing this in the setting of infection or skin that's not necessarily compliant, then this might not be as effective, but definitely something to talk to your plastic surgery colleagues about. Again, most common for skin grafted ventral hernia. There is a risk of developing a complication of the implant itself, and if that's the case, you would want to take that out prior to doing your hernia repair. My conclusion slide, again, fascial closure is important. These are tools that have been studied, but need, I think, a little bit higher quality of evidence, not only to tell us how to use them, but to help standardize protocols. When you're thinking about wanting to get skin and soft tissue coverage, consider tissue expanders, talk to your plastic surgeon colleagues, people that are familiar with this. And then, for all of us in the room, continue to study. Hopefully we get some answers here in the near future. Thank you.
Thank you so much. Going to our next speaker. Next speaker is Courtney Collins. a clinical associate professor of surgery at Ohio State University, Wexner Medical Center, talking about postoperative pathways and physical rehabilitation.
Hi, everybody. So I'm Courtney. I'm from the Ohio State, which has beaten both of these people in college football in recent memory. So, hi guys. Horns down. Okay. So I'm going to be talking about, I've actually changed it to perioperative pathways as well as physical rehabilitation. I don't have anything really substantial to disclose. I correctly guessed that most people would present the data and numbers before me. So I'm going to stay away from that and focus a little bit more on implementation science and how to approach kind of starting pathways at your hospital. I'm also just want to set expectations really low. I am really bad at making slides. They're very millennial, they're very cringy. So just lower your expectations right now. I'm doing my best. Okay. So when you look at this, the use of perioperative pathways really has exploded in the past few years, and that's because they really fix everything. I mean, if you're looking for like literature on perioperative pathways, they fix all of the outcomes. Length of stay gets shorter, complications go down, patient satisfaction goes up because they're getting out of the hospital faster. It's less cognitive burden for the team because if you just sort of have things on autopilot, it's less kind of micro decisions you have to make every day. They facilitate multidisciplinary care because you're getting more teams involved kind of automatically without having to think of it. And then I'm always have kind of an equity lens on, and I think when you take variation out of care and people don't have to make so many decisions, it makes care equal for everybody, no matter where they come from. So when I was doing this, I was like, that's it. That's the talk. Everyone should just be on a pathway, and that's fine. And they probably already are because evidence supports this so well. But when you actually look at implementation of pathways, and I'm going to use ERAS kind of as a substitute for pathways because it's the most well-researched type of perioperative protocol. We are really bad at implementing these. A recent review showed that when you look at colorectal ERAS, which is kind of the grandfather of ERAS, and they looked at a bunch of major centers, they found compliance, which they defined as being compliant with most of the standards in most of the patients. It really ranged from about 15% to at best around 70%. So this is something that we find really, really challenging. And so why is this? Because if it's so well supported by evidence, like everyone in the panel has been talking about, what is the problem with implementing pathways at hospitals? Scarcity of resources is one. Some of these pathways seem very overwhelming or require a lot of teams that hospitals may or may not have. Something we found at Ohio State when we're trying to kind of overhaul some of our care pathways is that even if you do have everything, they kind of exist in their own universes, and it's very hard to get people to sort of move in the same direction. Culture is a big one. Despite all of the evidence, it's very hard to get surgeons to do things that they don't want to do. And we've all had protocols that we've built that are beautiful on paper, but then kind of lead to nowhere. So everyone's executing them perfectly, but don't lead to the outcomes that you expect. And then honestly, people are tired. If you ask people to do one more thing, they are absolutely going to tell you no. And this is getting worse and worse, as we see more documentation, implementation of more things. But I would say the biggest barrier to implementing effective perioperative protocols is you people. But all of the systematic reviews that look at really important barriers to implementing these things say that leadership confusion and surgeons who don't really want to go along with all of the protocols, so it's kind of a protocol and kind of not the protocol, so does the protocol even matter, is one of the biggest areas, identified areas that need improvement. So what I want to talk to you guys about today is how do you start making some kind of perioperative pathway in the ab wall space? We are not traditionally an ERAS pathway. Many of us are on ERAS pathways, but we weren't sort of traditionally in that fold. And so how do you go about creating a path where there may not be one at your institution? And so I started this by drawing out this really nice board of like the perioperative process at Ohio State, and that got really, really confusing. So I decided to use this instead. So everyone's journey sort of starts in the clinic. And this is where you have your surgical discussion, where you outline everything, get everyone on the same page, and have expectation management. You then go to the pre-op space, where you then have optimization, which we've heard a lot about, things like nutrition, pre-op evals, your adjuncts like physical therapy and Botox. You move to the OR day, which is where you things like perioperative fluids, day of blocks, which I think are very important, and all the OR stuff, Foley's, drains, extubation. Then the floor. So things like early mobilization, pain management strategies. This is where ERAS protocols come into place, I think I would argue the most. And then post-op, where you have your follow-ups and your post-op physical therapy and your post-op adjuncts. And hopefully you all live happily ever after. So When you look at this, though, I mean, this is kind of the problem, right? Is when you're trying to make a pathway, this is extremely overwhelming. Like this is to kind of synergize all of this care into one pathway. You're like, there's just no way, and you're going to start, and you're going to get frustrated, and you're going to stop. And so this is why I think we see so many implementation issues. I would argue, though, if you look at something like this, what I really see here is multiple opportunities for streamlining in multiple different arenas. And I think that's really how you have to think about it. There is no way you're going to be able to streamline all of this in one go. So what do? The first thing is you have to map out your own path. What does your patient's perioperative journey actually look like? Where are they going before surgery? Who is talking to them? What is anesthesia saying day of? What is the nursing doing? And then you can kind of figure out some high yield areas to attack. And when you do that, you want to find areas that are easy wins. So you want to, for example, existing order sets are great. If you don't have an ERAS protocol, make one. If you have an ERAS protocol, update it the way that you want it updated. And then find services that you're already engaged with. So if you're looking at your perioperative pathway and you've never spoken to a physical therapist at your hospital in your life, this is not the time to slam down a 20-page guide for physical therapy and have them start from scratch. But if you do have a really good relationship with, anesthesia or your nurses, start there and see if you can start streamlining and making things protocolized in places where you already have strong relationships. When you do that, and I will tell you this from multiple mistakes I've made in my life, it's really important to get buy-in. Nobody wants to have protocols just slammed down in front of them without any discussion. And the way I learned this is I do a lot of work with our older patients at Ohio State. We're trying to add frailty screens to patients who get admitted to the floor, which seems like a no-brainer. Like, that should, we're like, oh, it only takes 2 minutes. But when I got a printout of all of the things nurses do when they take patients onto the floor, it's absolutely overwhelming. So you want to really understand where they're coming from and listen to suggestions they have, because that's how you get buy-in in the long term. I'm in my de-implementation phase. So I really think whenever you're going to anybody to ask them to do one extra thing, try and find one extra thing that you can take away. Because if we keep piling things on, you just get cognitive overload. And again, a decrease in compliance. And then this is where EMR has been truly, truly amazing. I came from an era of written order sets. So we had to write everything down. And so things got dropped all the time. Automatic order sets are gold. They can just foolproof things. They can, trigger automatic consults, things that you just don't have time to remember, that your residents don't have the time to remember. So make things foolproof where you can. But I think the most important thing really here is just to be creative. Where can you latch onto things that already exist? And so we have a floor we learned in at OSU that has all of like the high school like volunteers, and we've gotten them involved in our geriatric mobility program by having them get patients up to the chair. Where can you find something that already exists that you can latch onto? And this takes a lot of creative thinking. But most importantly, I think, whenever you start on a journey, it really all starts in the clinic. And so really taking time with your patients to tell them understand their symptoms, tell them what symptoms you can fix, and what the journey is really going to look like for them. It's very important to understand what their barriers to recovery are going to be and what their concerns are. And you have to manage expectations, explain every step over and over and over again, because if they sort of already know where to go, they'll help lead down the path on their own. That's how most hiking trails got started, right? Is people just walking the same direction over time, and it becomes a path eventually. So I couldn't think of a good transition. So now I'm going to switch over to the perioperative physical therapy part of this. This is a picture of my sister-in-law who last week decided that she didn't want to pay for an Uber from the bar. And so she got on a Lime scooter and fractured her ankle. And we promised we wouldn't make fun of her. So instead I put her in a national presentation. But she had surgery on Tuesday. She's in physical therapy today. Orthopedics has a very, very good understanding of the importance of perioperative activity. And they found that perioperative activity, both pre and post, increases strength, decreases pain, and leads to a faster recovery. And if any of you have hurt something orthopedic-wise, you'll know they'll actually delay your surgery so you can get physical therapy before to kind of get your tissues in the best shape possible. And there's multiple reasons for this. One is kind of to promote mobility and to keep tissues from getting stiff, but also when your leg is hurt, you kind of offset things and start using muscles differently in a way they're not supposed to be used, which can lead to other injuries. And so for now, PT is recommended for pretty much every orthopedic procedure with at least moderate, if not strong recommendations. So if you think about us, though, we kind of have the same thing. The abdominal core really extends from the diaphragm down to the pelvic floor and extends everything in between. And you can get hernias in all of these places. And this is one functional unit, much as a limb is, honestly. And so hernias can blow out any of these things. And so by making an injury in one part of it, it affects the function of everything. And this is borne out in the literature as well, where you see that patients who have hernias also report things like more back pain, they have more pulmonary complications, and they have more things like pelvic incontinence and pelvic floor dysfunction. So the abdominal wall really does function all together. So it seems like this is a really good corollary into the orthopedic way of thinking about physical therapy. So we actually proved this. My boss snuck out before I could show this picture, but we tested this at Ohio State. We put people on a little bouncy ball and saw how strong their core was. They wanted me to try it, and I said no, because you're going to take a picture of me and then you're going to use it in a talk, and that's what happens. And then we calculated their core stability, and we found that for patients with hernias, their entire core stability is thrown off, even for small defects and even for inguinal defects. So once you have some kind of core dysfunction, it throws off the way that you use your entire body. So we at Ohio State have started a physical therapy program, and I'm going to have a QR code so you can get it yourselves. And the important thing about this is it encourages early mobilization. Our early results suggest that it does have improved core strength. Those results are still pending. But I think almost more importantly, the qualitative results show that patients really appreciate this. It helps them get back to their function. It helps them feel more active after surgery. It helps them feel like they can move safely, which I think for abdominal core procedures is key. We have a pre and a post-op component. You can use both, or you can one or the other or both or whatever you want. And we also have an in-hospital part. If you want to do this at your hospital, which I think everybody should, I think it's important to have a holistic approach. So remember that, this is where you want to engage your physical therapist, especially your pelvic floor ones, because remember the abdominal wall is really an entire functioning body. So you want to make sure that physical therapy addresses all of those areas. This is a very new concept to patients, so it's really important to have conversations with them in the clinic about what this looks like and why it's important, because they're going to think it's kind of weird because they think of physical therapy as kind of an arm leg sort of thing. The nice thing is, as hernia patients get older, a lot of them have been to physical therapy before for knees and hips and that sort of thing. So it tends not to be a foreign concept, but it's something just to be reemphasized. Make an easy to understand guide for patients and a physical therapist guide, because importantly, so at Ohio State, because we're literally next to the football stadium, you can't stop physical therapy from seeing anybody. Like you have to beat them off with a bat. There's physical therapists everywhere. That isn't the case everywhere, obviously, but patients can find their own physical therapist and you can provide your own guide to them. It's really not that complicated, especially for, well-trained practitioners. We have found that one of the most important parts and something patients appreciate the most are things to do at home, but also tips for ADLs, so activities of daily living. It's pretty easy to just sit on your couch and not use your leg, but you use your core for literally everything. And so for patients, this creates a real fear that when they move and they hurt and starts hurting, that they're doing something bad. So they really appreciate having ways to get off the couch, ways to get in the car, ways to get out of bed. And then, sorry, last thing is biofeedback and tracking. So having some ways where patients can monitor their progress kind of keeps them engaged in the process. And also you can kind of help see patients' advances over time. So again, that's kind of what I want to go back to is I know that we kind of go to all these talks and we hear all the data about how all of these complicated protocols are really good things. And I think they are. But remember, if you don't have one, just start somewhere small, because everything that we do surgically at some point was a crazy idea that everyone thought was insane. But if you can start doing things routinely, then it becomes routine and then you don't really have to think about it anymore. So that is all I have. I look forward to the discussion if we have any time. Thank you.
Thank you so much, Courtney. That was a really great implementation talk. So running kind of short on time, even though I do think we have a 30-minute break. So we thought we would open up for questions from the floor first and see if there's anybody who had anything specific that they wanted to ask our amazing panelists. Don't all speak at once. Oh, yeah.
Kent, I had one question. I remember about 10 years ago, Michael Rosen taught us that during your preoperative consultation, you should be aware of the role of the patient. You can do a top-class abdominal wall reconstruction, but the patient also needs to work for it. So he needs to lose weight, stop smoking, and his glucose should be normal. And if he doesn't do that, he doesn't get the top-class procedure, but he gets an open eye bomb, for instance. From the literature you presented, I get the impression that of those three factors, only glucose control is more or less important. Does that change your practice, and does it affect the type of procedure, or do you refuse surgery?
Yeah, that's a tough one. Of the three, I do think glucose is probably the one that you can get the best handle on. I mean, obviously smoking cessation is very difficult. Changing in weight, it's tough to move the needle, particularly in hernia patients with large volumes of viscera in the hernia. But glucose control is something they can actually work on. And I do think that's part of the give and take. If the patient is not willing to try to improve their A1C or their day-to-day glucose control, then I will try to delay the surgery as much as possible. Occasionally, I will change techniques. Sometimes I will just bail out and do an IPOM on someone who doesn't meet all the optimization criteria, because if you burn a tar bridge, for example, on someone who's not optimized and that fails, then you have nothing left to offer.
Anyone from the floor wants to add something to that?
I was just surprised we didn't talk a lot about weight loss surgeries.
Sorry?
I was surprised that we did not really spend any time talking about getting your hernia patient a weight loss operation ahead of time. It's definitely part of our protocols. We do it pretty frequently. It does not delay care substantially. Many of these folks can go through the program in a matter of weeks, and it works very well. And I'm just, it's a new element that I don't think we talk enough about.
I have a quick question on that. So in this day and age with GLP-1s, do you feel like your patients are less resistant to undergoing bariatric surgery? Because I think there's a lot of people that I counsel that really want to try the GLP-1 route before considering bariatric surgery. And I think, across the board, we've seen a real decline. So, I mean, what's your way to manage that? And if patients are not successful in like 3 to 6 months, do you offer something else?
And the main point that I make to them is that they can do it any way that they want. The goal is to get them to an operation for hernia quickly so that the hernia does not become massively large in the interim. And diet, exercise, medications take much more time for weight loss than a safe and effective surgery. And maybe I'm a pretty good salesperson because they all seem eager to get sleeves when I talk with them.
And I think it's important to think about the patient, because to Dr. Pauly's point, you don't want somebody that comes back to your office in 6 months and has failed a GLP-1 and now they're just starting the bariatric pathway, because that is the ultimate delay. So it's got to be really individualized. What are your goals as a surgeon? What do you feel comfortable doing? And how quickly can we get them to surgery?
Our pre-op pathways, if they decide to do a medicine or whatever else, a non-surgical route, they get a telephone call with one of our APPs who kind of run a pre-optimization clinic. We do that for our smoking patients who are trying to quit, and we do that for our weight loss patients and for our diabetes patients. So someone is checking up on them to make sure that, as Dr. Arroyo said, they don't show up 6 months later having failed everything, and the hernia is bigger and they're still not ready for surgery.
I think the GLP is an easier sell than a sleeve. It's way less invasive. I love the idea of ESG. We're starting to do that in our institution in balloons. I mean, I don't think there's any magic to it. I agree. You're just trying to get them to lose enough weight to make them suitable for surgery. The problem with sleeves that we run into is sometimes that patient really has no interest in bariatric surgery, and you're almost trying to get them to buy into something they really don't want in the first place. They want their hernia fixed. So I find that a tough sell. And some insurance plans are mandatory 6-month medically supervised weight loss, and the workup might take 8 or 9 months to get into the OR. And in that time, the hernia usually is too symptomatic to make them wait.
I had just one question, Courtney. You showed us what the bone bros do. I'm a trauma surgeon, so I'm also one of the bone bros. So you showed the advantage of early moving and exercise and those. I operate more and more older patients with traumas, but it's more or less the same with abdominal wall surgery, I think. How do you think the mental support post-operative is important? Is that an unmet need?
The mental support post. Yeah. I mean, I think that especially for these big surgeries, that can be one of the most challenging things. So I think it's very important in that preoperative conversation to really outline what a major reconstruction is, because most people know someone who's had a hernia repair, but they're picturing the small thing, and they're like, this is going to be a small thing. It's going to be a small deal. And then they also, I think, get very nervous then when it hurts a lot after surgery, And so I think you have to be really honest in that in that initial consultation, be like, they're like, oh, is it gonna hurt? And if your answer is anything other than yes, like you're a bad doctor, right? Of course it's gonna hurt. Like it's gonna hurt for a long time, you know? And so how to manage that and, you know, what the time course really looks like, I think is really, really important. You brought up older patients though, which is something near and dear to my heart. Older patients, I think, respond really actually really well to this kind of perioperative activity thing, mostly because they're retired and don't have a lot to do. So, and they tend to be very compliant. So I think that they're actually, if we're gonna do physical therapy or any of this activity, I think that's actually one of the biggest populations to really emphasize it in.
That's great. Some really good advice. Any questions? Otherwise, any last comments from the panel? We're only 5 minutes over, so actually doing quite well. All right. Well, thank you guys all so much for your expertise. This is amazing talks. I learned a ton. And if any of you guys want to come up and find our panelists afterwards, please feel free to reach out.
My videos never work, so I'm just sticking to me. I'm sticking to me. I just stick with what I know.
No.
Con ese tema del Botox,